let's start with presentations. And let us start with Miss Young. Miss Young, you're all ready to go. Can you tell us, we just want to know the muscles that basically cross over the glenohumeral joint, shoulder joint, and therefore can move the shoulder joint. It's a quick review. Miss Young, you there?
Yep.
Cool.
And I'm going to pull up my presentation so I know everything.
Awesome. Take it away. Do I need to be showing your presentation or anything?
I guess I don't need to.
No, I meant do I need to?
No.
Okay.
Because I can just pull it up on here.
All right. You go.
Okay. Forgot how to do this for a second.
You're okay. Okay. There we see it. Nice job.
Yeah, it's very boring.
No, this should be boring. This is already fantastic. Seriously.
So, muscles that move the glenohumeral joint. So, I already explained this before, so I'm not really going to go into it again. But,
Good.
as you can see, this is the glenohumeral joint.
Perfect.
So, the muscles that can extend the glenohumeral joint are the latissimus dorsi, teres major, deltoid, the posterior fibers, tricep brachii, and the pectoralis major lower fibers. The muscles that can flex the glenohumeral joint are the pectoralis major upper fibers, the bicep brachii, and the coracobrachialis. The muscles that adduct the glenohumeral joint, latissimus dorsi, teres major, infraspinatus, tricep brachii, coracobrachialis, teres minor, and then the pectoralis major upper fibers horizontally. Oh, abduct. Great, I put that in the wrong one. That's what I get for doing that at like 8.
And I think they horizontally adduct. But anyway, yes.
I don't know. I can't read. And the muscles that abduct are the supraspinatus.
And deltoids.
Oh, really?
Yeah.
Dang.
You're okay. Keep going. You're doing great.
Okay, and then the muscles that rotate. Muscles that medially rotate are the latissimus dorsi, teres major, subscapularis, and the anterior deltoid. The muscles that laterally rotate are the infraspinatus, teres minor, and posterior deltoid.
Beautiful.
And just a little extra, because it told me, some of the things that stabilize the glenohumeral joint are the infraspinatus, teres minor, subscapularis, and supraspinatus.
Beautiful.
And that's it.
Miss Young, one question. That was absolutely fantastic. I really mean that. It was actually more than what I asked for. You actually gave me the muscles that go with actions, which I really like. Those last 4 muscles you showed that stabilize the shoulder joint, they're all part of one muscle group. What do we call that muscle group?
Oh my goodness. I don't remember.
That's the rotator cuff group. Yeah,
okay.
They're known to stabilize the shoulder. Anyway, that was fantastic. Perfect. I'm glad it was boring, and it really wasn't boring. It was better than my presentation. It was great. It had visuals. You put together, also by putting all the flexions together and all the extensions together, we're starting to see that no longer are we studying one muscle, right? Usually when I do a flexion, I really am using 3 or 4 muscles. That's beautiful. Thank you, Miss Young. Perfect. Mr. Thornton, muscles that move the scapulothoracic joint.
I am here.
Awesome.
The scapulothoracic joint is made up of the scapular shoulder blade. It's articulation with the rib cage.
Sure.
In between these structures are 2 muscles, namely the I'm always getting messed up with that. Subscapularis, one of the rotator muscles, and the serratus anterior.
Okay, but the subscapularis does not move the scapulothoracic joint.
There's actually 15 of those.
So what muscles move the scapula around? That means they hook to the scapula and hook to the body. Serratus anterior is one.
There's the trapezius,
Yes.
supraspinatus.
No.
Huh?
Supraspinatus hooks the scapula to the shoulder so it can't move the scapula. This stuff has to anchor the scapula to the body. Does that make sense?
Yes.
So you're right, by the way. We've got serratus anterior, trapezius,
Teres minor.
teres minor again goes from the scapula to the
Oh, wait, I have
arm.
it here. Hold on, I'm tripping. I have it here.
In a way, you're kind of answering Miss Young's question. But think of the stuff that attaches to the medial border of the scapula, for example.
Rhomboid major.
Rhomboid.
Pectoralis minor.
Yes, but since you're absolutely right about that. But you said rhomboid major, let's also do rhomboid
Minor.
minor. Above rhomboid major and minor is the thing that elevates the scapula.
Levator.
Yep, levator scapula. And then you said serratus anterior. Those are the things that attach to the medial border. That's excellent. And you said pec minor, and you said trapezius.
Mm-hmm.
People could argue the latissimus dorsi because it grabs on to the scapula a little bit and hooks to the body. And I think that's it. Did I miss anything in here, everybody?
No, that's it.
Cool. Thank you, sir. Miss Stevens.
Yes.
Yeah. Miss Stevens, you were briefly, don't feel like you have to go on a big long thing. We're going to remind us about what the muscular system is.
Okay. Can you hear me okay?
Yeah, actually perfect.
Okay, cool. So the muscular system is an organ system consisting of skeletal, smooth, and cardiac muscles. It permits movement of the body, maintains posture, and circulates blood throughout the body. The skeletal muscles are attached to bone by tendons, and they produce all the movements of the body parts in relation to each other. The smooth muscle is also called the involuntary muscle. The smooth muscle is found in the walls of hollow organs like the intestines and stomach, and they work automatically without you focusing on it. They just do it without you having to think. The cardiac muscle makes up the thick middle layer of your heart. The muscular system is responsible for the movement of the body. It's attached to bones of the skeletal system. There's give or take 700 named muscles that make up roughly half of a person's body weight. Each of these muscles is a discrete organ constructed of skeletal muscle tissue, blood vessels, tendons, and nerves.
Yeah. Cool.
That's it.
That's perfect. By the way, I just didn't want to interrupt you, so I was pausing. That's perfect. Nice and tight. Thank you. Thank you. Mr. Snell, skeletal system.
Yes, sir.
Can you tell us about Yeah, thank you, sir.
Okay, so yeah, I had the skeletal system. So the adult human body consists of approximately 206 bones organized in the body. There's 5 functions of the skeletal system. It helps with movement, support, protection, makes blood, and storage. There's 2 major skeletal system parts, with those being axal and appendicular. The axle consists of the skull, spine, ribs, and sternum. And the appendicular is the shoulders, arms, hips, and legs. There's 4 basic bone shapes, those being long, short, flat, and irregular. And that's about it. That's all I got.
That's cool. Perfect. Thank you, sir. Thank you. Okay. Mr. Singletary.
Yes, sir.
The integumentary system. I don't even know what that is. What's the integumentary system?
You're gonna have to help me with a couple of the glands because I don't know how to pronounce them, but I'll chime you in when I need you.
All right. I hope I do too. Okay. Thanks for the heads up, Mr. Singletary. All right, go ahead.
Basically, the essence of the integumentary system is to protect the body from infections and to regulate the body's temperature. Additionally, the integumentary system protects the living organs of the body by preventing foreign agents from entering the body. The integumentary system also helps with getting rid of waste, with sensations of the body playing a big role in the system, like pain and pressure, like we do in your massages. In terms of protection, the skin prevents bacteria, viruses, and other foreign agents from entering the body. However, if bacteria has entered the body, this is when vitamin D and your white blood cells get triggered to fend off harmful bacteria in the body. For an average adult, the skin covers about 3,000 square inches of the surface of the body, and the skin alone weighs about 6 to 7 pounds by itself. Within the body, melanin is produced, which in turn helps protect us from damaging ultraviolet rays of sunlight. Also, keratin is produced to help prevent an outer layer called the epidermal water barrier, which assists in waterproofing the body. So basically, without this protection, a simple activity like just going swimming in a pool in chlorinated water, that could prove to be a problem for us. In terms of the skin by itself, it has two principal layers. We all know them as the dermis and the epidermis. The epidermis is a thin outer layer, and the dermis is a thick inner layer of the skin. The epidermis is relatively avascular, meaning without blood, and as the dermis would be providing the nutrients by tissue fluids. The epidermis has small openings which allow for us hair to pass through the skin. Conversely, the dermis, also called true skin, is a thick layer which consists of dense connective tissues. The dermis's purpose is to cushion the body from stress and strain. Additionally, the dermis is broken down into two layers, which are the superficial area adjacent to the epidermis, called the papillary region, and a deep, thick skin area called the reticular dermis. The integumentary system has another important function, which is the regulation of the body's temperature. The blood vessels in the integumentary system go up whenever the temperature increases. If this happens to our bodies, we would begin to sweat in order to regain control of our body's temperature. In addition to temperature control, the body has sensory receptors in the body. These receptors respond to cold, heat, pain, and other changes to the body. The nerve that is in this area is simply called sensory receptors. These receptors receive stimuli from the external environment, and the stimuli from the receptors travel to the, okay, you're going to have to help me with this one. It's spelled P-A-R-I-E-T-A-L. Is it parietal?
Oh, parietal.
Parietal. All right, thank you. Parietal lobe of the brain. This sensory is called the, one more help, Mr. Tafscott, S-O-M-A-T-O sensory cortex.
Say it one more time. I think it's somatic.
Somatic, okay, somatic. Because it's S-O-M-A-T-O sensory cortex. I'm not exactly sure how you pronounce that.
Somato?
I guess that's
I'm actually not familiar with that word.
I was lost too, don't worry. What was I saying? This is extremely important because this sensory determines the type of sensation that is felt and where the sensation is located.
Oh, yes. Sorry. Yes, it's an area of your brain that is completely dedicated to body sensation. It's actually very, very large in your brain because it takes a lot to process all the signals coming in. Yes.
Okay.
Essentially, it means the body. The word actually means body in Latin. Yeah.
Okay. When there is a change in the body's temperature, for example, the hypothalamus goes into action when it senses a change in the body temperature, and the hypothalamus seeks to restore our bodies to normal temperature. This is basically called thermoregulation. If the body cannot regulate the temperature, it could lead to hypothermia, which is excessive decrease in body temperature, or hyperthermia, which is excessive increase in body temperature, both being deadly to us. And for the skin glands of the integumentary system, there are 4 major skin glands. This is where I need your help again. The sebaceous.
Yes.
Sebaceous gland. That's how you pronounce it.
Yep. Sebaceous.
Sebaceous. or commonly known as oil glands,
Yep.
produce a substance called sebum. Am I
Sebum.
pronouncing that right?
Yeah.
Sebum. Its job is to lubricate your hair and the epidermis. Too much sebum can cause oily skin, and conversely, too little can cause dry and flaky skin. The sudoriferous gland, or what we know as sweat glands, generally consists of secretory oil that secretes a substance onto the skin surface by way of a duct. Their primary function is to assist with regulating the body's temperature and also to eliminate waste. For the average adult, there are about 2 million we have about 2 million sweat glands. The third one is the ceremonious, ceruminous, CERUMINOUS.
Say it slower. CER.
CERUM, serum.
I know exactly what this is. I'm just having a hard time visualizing. CER.
Ceremonious.
Oh, I have to see it.
Okay, I'm sorry.
No, you're absolutely fine, sir. I should know this right off the top of my head.
No, it's okay.
That's why I was making that.
It's a specialized gland that focuses on the production of serum, CERUMUN. It basically is earwax.
Yes. Oh, gosh, that's why it's not. Yes. We didn't even study this one in class because it's a gland that only exists in your ear and makes earwax. Yes, sorry.
No, it's okay. And then you have the, of course, the mammary glands for female breasts, and it's connective tissue that produces milk.
Yeah, it's amazing.
And that's it.
Okay, that was really good, sir. I have one question for you.
I don't.
You know the answer to this one. So you mentioned they said the skin's broken up in 2 main layers, which is true. There's all different ways to break up the skin. And you talked about the epidermis. It has 5 layers to it that we didn't get into in this class. I'm kind of glad. The dermis that you mentioned has 2 big layers in it. What is the 3rd layer? Under the epidermis, dermis, there's a 3rd layer down there at the bottom. It was fine that you didn't include it because some people don't include it with the skin. But what is that 3rd layer that's underneath, he said as a hint, the dermis?
I'm going to say something.
Sub starts with a C?
Okay,
Don't get cute with me, sir. Do not.
Because when you said underneath, I thought of sub, but you said it starts with a C.
And I said don't get cute with me, too.
Oh, that's a clue.
Yeah.
You got me. I'm sorry. I can't think of it.
All right. It's probably a superficial question anyway. Let me ask Mr. Jones. Mr. Jones, what are the 3 names for the stuff found underneath the dermis?
Well, you hit me with that. Come on now.
Well, you raised your hand, so I figured you were feeling extra bold, so I thought you could give me all 3 names.
I just noted as soon as you said that not to be cute, my brain was like, bing.
What's that one?
It's the subcutaneous layer.
Subcutaneous is 1. Do you have the other ones?
Now that I'm on the spot, give me a second. It's the dermis or the epidermis.
Epidermis, dermis, subcutaneous, and I want 2 other words for subcutaneous. Miss Eversole, hit us.
I know there's also hypodermis.
Hypodermis is another word for subcutaneous. That is excellent. So we've got hypodermis, we've got subcutaneous, and I need a super good answer for this last one, Miss Clayton.
Superficial fascia?
Oh, that was a super good answer. Okay, so we've got the cute, adorable answer, subcutaneous. We've got the superficial answer, superficial fascia. And we've got hypo, which means under the dermis, hypodermis. They're all the same thing. That was awesome. Thank you. Mr. Manzanares, can you hear me, sir?
Yes.
Excellent. Mr. Manzanares, what are you grateful for today, by the way? We never got to hear your gratitude, and it deeply depresses me.
Grateful
for the cool weather.
Cool. We'll take it. Thank you, sir. Welcome back. Okay. Thank you, Mr. Singletary. That was awesome. Thank you, thank you. Miss Clayton,
You're welcome.
you still have your hand raised up, but I'm assuming that's left over, Miss Clayton, or did you have something to say? Left over. Okay, good. All right. And we have time. Miss Savarino.
Hello.
Hello. You were going to tell us about muscle spindles.
Okay, I don't know why it's always a good idea for me to drink iced coffee before presentations, but
That's just like
I'm trying to
freaking
get
out.
to this. So,
It'll be the quickest
Muscle
presentation ever.
I know. A lot of pressure. Muscle spindles are receptors, and a receptor is a neuron responding sensory stimuli. But more specifically, like they're classified as mechanoreceptors, which detect movement or stimuli that change or deform their shape. So essentially, they are stretch-sensitive receptors wrapped around interfusal muscle fibers, which means that they are hidden within the rest of the fibers of the muscle and that they're sensory, and they monitor change in the muscle length as well as the rate of that change. And so they're activated when we overstretch them, or they're rapidly stretched and they cause a reflective contraction. So in like layman's term, basically they sense a muscle stretch, then they tell the muscle to activate, which facilitates the muscle's action. That's it.
Miss Severino, I really commend you on that. You took something that could have been a long, long thing, and she organized the material in a very, very cohesive manner. I want to repeat what you said, not because I just want to repeat it. So Miss Savarino told us these are sensors. They're at the end of nerves. Those long wires coming from my brain have to have something at the end of the wire to tell it when to go off. Some go off because of heat. Some go off because of pressure. This sensor is inside muscles, and it goes off when it's stretched too far or stretched too fast. It's trying to keep you from ripping your muscles. It sends a message to the brain, says, hey, and your brain's like, that is a muscle spindle going off. This person is dancing really wild at a rave and doesn't realize they're going to tear their bicep or something. And it will actually send us a reflex thing to stop you with an opposing muscle from going further. You'll actually fight yourself on purpose. And I love how Ms. Savarino also told us this is in a category of receptors. You have all sorts of different receptors, right? Just at the end of my finger, I've got hundreds because I need different things to tell me different things there. But these are called mechanoreceptors. They tell me about the mechanics of my body. How far am I bending? How fast am I bending? All that kind of stuff. That's what mechanoreceptors do. What's important about muscle spindles is they tell us one of the reasons why we go slow in massage. If I rub you really fast, it's fine if I rub you really fast to warm you up and get blood going, but if I stretch your muscles really fast and rub you really fast, what it does is actually make you unconsciously tense up. I set off your stretch receptors. And I do not want to do that. I do not want to set off your muscle spindles because they're designed to actually stop me from doing that type of stuff. So that was perfect. I can't believe how succinct it was. I really like that. Bam.
Thank you, Mr. Tapscott. Appreciate it.
Thank you. Maybe the coffee's working for you. I don't know. Yeah.
Maybe I'm going to start drinking coffee every day now.
Oh, God. You are not a person that needs a lot of coffee. Trust me. Trust me. Miss Everson, you raised your hand.
When you're giving massage and someone's leg, like you're doing a stretch to maneuver their leg and you're massaging their infraspinatus or semimembranosus, semitendinosus, and bicep femoris.
The hamstrings, yeah.
They give you your, like, they don't give you their leg. Is it their leg trying to, like, stop the stretch from happening?
No, probably not. In that case, that's probably them having a hard time letting go of their body. And by the way, everybody, that's normal. So I will ask clients one time to like, hey, you can relax, you can let go. I don't ask them again because it just makes them self-conscious. It makes them feel like they're failing at something. And the fact is, here's why it happens, really, Miss Everson. Your whole life, who's been moving your body? You have been. And so when all of a sudden I'm like, let me move your neck for you, you're like, I've never had anybody move my neck for me. And we anticipate what you want us to do, and we help you do it. Like, that's what we do. Like, it's really hard for somebody to just be like, Let it all go. And so that's probably what's happening is they can't help but lift their leg for you. And the reason I don't ask them to relax more than once is because all it does is make them hyper conscious of their leg, and now they're going to help me more than ever. Sometimes I will tap on somebody else's area of their body and say, hey, can you think about this spot here for me? Don't tell them to let go of the leg. Tell them to think about, and I actually touch the spot. I don't do their face. That'd be kind of weird. I'll tap on their shoulder and I'm like, hey, think about this spot on your body for me if you could, because that helps. Don't tell people not to think about the pink elephant in the room in the tutu. Because they will think about the pink elephant in the room in the tutu. Okay, very cool. That was great. Mr. Richards, along these same lines, you are going to tell us about Golgi tendon organs, or Golgi tendon complex, people call it too. And I can't wait. Sir, take it away.
Mine's similar to Sav.
Yes, it is.
So, Golgi tendon organs are tension-sensitive receptors located at the musculotendinous junction.
Mm-hmm.
And what it does is it sends signals through the nervous system, central nervous system, through the axon nerve, and it's when you're contracting a muscle, depending on the weight. So if the weight's too great, it kind of sends a signal saying, too heavy, too much. So then it puts a stop on that contraction. But then what it does is it stimulates the antagonist. So the antagonist kicks in, so it doesn't cause tears or damage of the tendon, because a tendon attaches muscle to bone. And that's it.
That's really well done.
Good.
Can you read the first sentence you said again? It was perfectly right. I want to break it down for everybody. The first sentence you said.
Are tension-sensitive receptors located at the musculotendinous junction.
Okay. So musculotendinous junction. It's where the muscle turns into the tendon and attaches to the bone. It just sounds very fancy. But these, by the way, Golgi tendon organs are, again, nerve sensors. They're at the end of nerves. Every nerve is just a wire, right? It can only send one signal. It can only send dee, right? It can only be on or off. And so you don't just have one nerve going to a small area in your body. You have to have a nerve going to a small area in your body that senses stretch. One senses pressure. You have to have another wire sensing temperature, all going to this one area. And your brain gets back various signals from those and puts those together into sensation. They're all light switches, and they go off for different reasons. I hope that makes sense. Anyway, the Golgi tendon organ is found mainly in your tendons. However, it is also found in every part of the muscle, because remember that tendinous material is found throughout the muscle. And its job is to keep you from tearing. And so it will try to stop a stretch as well. Usually Golgi tendon organs shut down that muscle when that happens, and usually muscle spindles actually fire an opposing muscle to stop that. But they both are trying to stop you from tearing. Golgi tendon organs are especially sensing too much pull. And you're literally going to rip the tendon off your body, and they want to stop you from doing that. So they're very important. And both, we're going to tie in muscle spindles and Golgi tendon organs and this next thing that Ms. Rader is about to tell us about into PNF stretching. So Ms. Rader, can you tell us about reciprocal inhibition?
Yeah, hold on one second.
No problem. Take your time. If you need more time, we can take our break right now, Ms. Rader.
Well,
No, I'm good.
I did a lot more, but Sav was my inspiration to break it down. So I did have loads. All good. Thank you, Sav. Thank you.
If you want to do it, you can. I don't want you to feel cut off, sir.
It's all good. It's all good.
Okay.
I'll follow the leader.
Okay.
That's all good.
All right. I feel very bad. I don't want to press you guys to do like a 4-hour presentation. I also don't want to stifle you either. But anyway, as long as you're good, I'm good, because it was a very good, tight explanation. All right.
Can you see my screen?
We can. Thank you. Thank you.
Okay. Yeah, I don't know why it looks so small like that, but
It looks good to me.
mine is also. What's that?
Well, of course, I'm on a big screen TV, but it looks great to me.
Oh, okay. So mine is also similar to Mr. Richards and Mr. Savarino. I did reciprocal inhibition. And so basically what that is, the theory of reciprocal inhibition, which is stated by Susan Salvo, not in this book, but in some other book, when the central nervous system sends a message to the agonist, which is the muscle causing a movement, to contract, the tension in the antagonist, which is the opposing muscle, is inhibited by impulses from motor neurons, and then that muscle has to simultaneously relax. So motor neurons are also called efferent neurons, and they transmit impulses from the central nervous system to muscles or glands. This is important because it means that the muscles work in pairs to protect us from injury. So if both of the opposing muscles contracted at the same time, not allowing the other one to relax, then a muscle tear can occur. This tear would end up happening in the weaker muscle. So for example, if both the quads and the hamstrings contracted at the same time, the quads are typically the dominant muscle, so you would end up with a tear in your hamstring. So this is useful to us as massage therapists because we can help our clients by relaxing their tight muscles. So if they have tight hamstrings, we can get them to relax by contracting the quadriceps. And if our client has tight pectoralis muscles, then we can contract the trapezius, middle fibers, and the rear deltoid, and that would help relax the pectoralis muscles. This also helps us with cramp management. So if you get a cramp in your leg, you have a cramp in your gastrocnemius, then you would activate the tibialis anterior by dorsiflexing your foot, and then that action would cause the gastrocnemius to relax, to ease our muscle cramp. So the bottom line is that when one muscle contracts, the opposing muscle's tension is blocked by receiving messages from the central nervous system. Reciprocal inhibition is designed to prevent us from injury, and we as massage therapists can help our clients by applying this theory to ease the muscle tightness, and we can save ourselves a lot of pain by applying reciprocal inhibition to stop muscle cramp.
That's beautiful. Wow.
The end.
That was great. Ms. Rader, can I ask you a big favor and put you on the spot? Can I use you as a model? Can you come in here for a second?
Okay, I'll be right there.
Thank you. Everybody, I want to tie, that was perfect. What she did was perfect. I want to now tie these three things together in something called PNF stretching. I think what I'm about to show you is extremely important. So, and we can show you again in lab, but I really want you to follow along so you understand why it works. This is an advanced form of stretching. Hold on, I'm going to silence her. Advanced form of stretching. All right. Okay, so we just heard about three things. We heard an excellent presentation on muscle spindles. We heard an excellent presentation on Golgi tendon organs. We heard an excellent presentation on reciprocal inhibition. By the way, we heard other excellent presentations, but I'm talking about these three. Okay? So, this is a fake demonstration. All right? We're not really doing this because I usually do this especially with people's legs, because legs seem to be where they have a lot of tension that's affecting their upper body. But I'm just going to try to make a point. I need to have a body to make this point. Number one, muscle spindles. Are your shoulders okay? Okay. Muscle spindles are the reason that when I go to stretch her and I want to get her arm to go up higher, and I want to stretch her, that I don't do it like this. Because if I stretch her fast, her muscle spindles kick in. And her muscle spindles kick in and stop me from stretching her. The one way I can guarantee to set off a muscle spindle is to go fast. By the way, I can almost guarantee that I'll tear her muscle and get a lawsuit too. So you're going to piss off the muscle spindle, I'm going to piss off my lawyer, all sorts of stuff. So muscle spindles are why we stretch slowly. And massage therapists outside of the school will tell you things like, I can tell how far to stretch a client based on the tension that I feel. I'm going to be bold and inappropriate here. That is a load of crap. Do not do that. If you try to stretch my quads by bending them back, I bet you could stand on them. And it won't be enough for me. That's a tremendous amount of tension. If I do it to you, it's quite possible I could push, not because I'm better or something, just because we're different. She might be feeling pain when I'm barely pushing them back. You cannot do it by tension. The only person that knows how far to stretch is her. My client. That's why stretching takes so long. I literally have to be like, oh, I'm feeling some tension here. Can I go further? She's like, yes, you can. And I'm not only listening to what she's saying, I'm listening to the tone of her voice. Because sometimes people are like, yeah, you could go a little further. And I'm like, okay, we're close, right? But she gets to decide. So that's muscle spindles, and you've got to check with the client every time. There's no other way to do it. Cannot be done. Don't listen to somebody who tells you otherwise. I'm very opinionated about this. You'll be sorry if you don't listen. That's muscle spindles. All right. Now, here's the other thing, though. Golgi tendon organs. Golgi tendon organs try to keep her arm from going too far. But Miss Rader doesn't usually walk around doing this all day long. It's not a typical thing to do. So her Golgi tendon organ is probably set short. It's set to stop her here, even though she can go here. Okay? And so what we can do is the Golgi tendon organ, remember, it's sensing the amount of force on there. So this is hard to visualize, but think about this because it's super cool. When she gets up here, she's feeling a certain amount of stretch down here in her latissimus dorsi, by the way, and therefore teres major, all that stuff, right? But she's feeling, let's say she's feeling, I'm picking an arbitrary number, she's feeling 30 pounds of stretch here, and her Golgi tendon organ is like, we haven't been up here before, 30 pounds of stretch is plenty, we're stopping. And it stops her. But she can actually physically go farther. So what I do is I say, hey, Miss Rader, push down on my hand with about 10% of your body power. Well, that, I say 10%, by the way, because otherwise the client will, throw you back. That 10% makes this 30-pound stretch go to 40 pounds, right? Because she felt a certain amount of tension here. She's increasing the tension by pushing against me. And guess what? The Golgi tendon organ resets and says, oh, I should be at 40 pounds. Right? So she's up here, she's 30 pounds. I ask her to push against me for 10 seconds. That makes it feel like 40 pounds, and I say relax again, and now she can go up further. That's essentially PNF stretching. But we're going to throw in one more thing. That is PNF stretching right there. But I like to turbocharge my PNF stretching because I want to be better than all the other massage therapists. So I'm also going to use reciprocal inhibition. Reciprocal inhibition says that when I ask her to use her deltoid, her brain sends a signal to let go of her latissimus dorsi. Her brain tells her latissimus dorsi when she's lifting her own arm to let go of this. So I put all that together. I stretch her very slowly because of muscle spindles. And we're pretending here that she can easily put her arm above her head. This is all a joke. But we're going to pretend like she's stuck right here. And I'm going to be like, Miss Rader, can I go further? And she'll go, yeah, a little bit. I'm like, okay. And now we're maxed out. That's muscle spindle. We're done there. Next, she's feeling about 30 pounds or 4,000 pounds, whatever. She's feeling a certain amount of stretch here. I'm going to say, Miss Rader, can you press against me with 10% of your body power? Perfect. For 10 seconds, I go 10, 9, 8, 7, 6. That just told the Golgi tendon organ that can actually handle more stretch. So when she lets go now, she's got 30 pounds of stretch there, and I can push up higher. But I'm going to use reciprocal inhibition, say, will you help me lift your arm higher and assist me so that she gets reciprocal inhibition telling her to release. So we just put all three of those concepts together in this amazing stretch. First, we stretch our client up to where we think they can go to. We check in with our client. We get them as far as they can go. Then we ask them to push against us for 10 seconds. She's pushing. I hold her there. Isometric. I hold her. That tells her Golgi tendon organ can actually go further, can actually handle more than she thought. Then I ask her to help me lift her arms so that her brain sends a signal to the opposing muscle to let go. And we go further. And we repeat. And that is turbocharged PNF stretching. Thank you. I just had to have an arm to do that. Thank you. Mr. Richards, please.
So PNF stretches is when you're learning how to do the splits. You go down as far as you can, and then you access more, so you can go down a little bit further, and next time a little bit more.
Do you mean you flex your adductor muscles?
Yes.
Yes.
But when you're doing the splits, you go down as far as you can, then kind of relax a little, and then go a bit further.
That's different. What you just described is different. It's more that I go down the splits, then I try to lift myself back up, which activates those muscles, and then I try to lift them back down, yes.
That's it.
And by the way, this is why actually people that do yoga and ballet are so flexible, because they're doing this stuff under a load, which actually works very, very well. There is one other thing that happens during that type of thing that I just did with Miss Rader that they don't talk to you about. There's actually a strength component to stretching. This is, again, why people that do yoga are very flexible. They're actually quite strong. Because what happens is my body's very smart. Not only does it not want me to tear, it doesn't want me to bend over and be like, I can't get back up. Miss Rader, can you come in here and help me up? Right? So it knows not to let me go over too far. So if you make somebody push against you, they actually build up strength there, and the body goes, oh, I can handle going further. I'm strong enough to get back out of that position. So there's a strength component. But I want to be very clear. What we're doing is this is regular stretching. I push you as far as you can go. The client pressing against me, and I don't let him win. I hold him there. Client pressing against me tells the Golgi tendon organ that it was set too low. It can handle more stretch than it thinks it can handle. Them helping me sends a signal to release that muscle. So we're doing kind of three different things with this concept. And that is PNF stretching on steroids, essentially. PNF stretching stands for proprioceptive. What are proprioceptors? They are receptors that help you know. They're like mechanoreceptors, by the way. They are receptors that let you know where you are in space. They are muscle spindles and Golgi tendon organs and things that let you know how far you're bending, how fast you're bending, how much stretch you have. Those are proprioceptors. They give me, proprioception means to see oneself. Proprioceptors are the reason that I know that I'm bending my arm without looking at my video or looking over at my arm. They tell you, you take this for granted because you're just like, I know I'm bending my arm, but how do you know you're bending your arm? I can feel it. That's exactly right. How do you know you're bending at 90 degrees? I can feel that. That's a proprioceptor telling you that. Anyway, proprioceptive neuromuscular facilitation. That's PNF stretching. Proprioceptive nerves, muscular facilitation. We are facilitating using these proprioceptors to get you more of a stretch. And it's very effective. You'll get instant stretch gains on people. It's really helpful when you're doing things like hamstrings, things like that. So the person, you lift their leg, they're laying on their back, they're supine on their spine, you lift their leg up as high as it'll go. Then you say, you check with them, is that as far as I can go? And they're like, yeah. And you're like, okay, we're there. Then I say, press against me with just 10% of your power, and I hold it there for 10 seconds. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. And then I go, will you help me lift your leg further? And they go, shoop. You'll actually see about that much difference quite often. Let's do it again. Press against me. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Help me lift it further. They help me. By helping me, they're engaging their rectus femoris, one of their quads, and that releases their hamstrings more, and we go up higher. You will run out. Like, they can only go so far, and then they'll be like, that's about it. And then I love to, at this last part, just hold it. Hold that stretch because I'm trying to reset their fascia. Hold that stretch for 30 seconds. You can hold it for 2 minutes if they'll let you, but usually they get kind of tired of that. And you'll know when you've done this too many times because they start shaking. And that's not a bad thing, but they've run out of power to push against you and the muscle's exhausted. And you just hold it there and let that set in, and then you let it slowly down. All this is slow. So that's PNF stretching. That is a very good place for us to take our break and come back. When we come back, we will be hearing from Miss Pugh very briefly. I only say briefly because I don't think it needs to be long, about chemoreceptors. So let's take a 15-minute break. Everybody, I'll see you back at 10:40. Photoreceptors.
Yeah, I got photoreceptors, so they are located in the eye and detect light stimuli. The two types of photoreceptors are rods and cones. Rods are located in the peripheral portion of the eye and perceive low light better than the cones, but they do not perceive color well. Cones are located in the central portion of the eye. They function better in light and perceive color much better than rods. That concludes my presentation.
Which would mean it would be hard in dim settings to actually sense color, right?
Yes.
Yep. And by the way, everybody, color is one of the things that helps you sense movement, too, because you sense kind of shifting things better when you see in color. so you'd have a harder time seeing movement at night too. Just throwing that out there from the evolutionary point of view. Thank you, sir. Beautiful. Ms. Osuna. Hello, ma'am. Will you tell us about thermoreceptors?
Yes. Okay. Thermoreceptors. Thermoreceptors are specialized neurons located inside the skin, and they help detect changes in environmental temperatures, which help maintain homeostasis. So they will detect heat and cold that are found throughout the skin in order to have sensory receptions throughout the body. The location and number of thermoreceptors will determine the sensitivity of the skin to temperature changes. This is important because it will alert the body to unusually cold or warm temperatures that might require an action, such as putting on a coat or shedding a layer of clothing to become more comfortable. If the temperature does cross a line that could be dangerous to the body, it will be picked up by nociceptors, which are neurons that are sensitive to pain. And these neurons fire to alert the body to the fact that it is freezing or burning, and that can prompt a response from us. And a study was shown that thermoreceptors that are sensitive to cold may also play a role in taste as well. So many people have noticed that the same food can taste different when it is eaten cold than when it is eaten warm or hot, and these neurons may be involved in the process. There are certainly a high concentration of cold cells around the mouth and tongue, indicating that the mouth has an increased sensitivity to cold temperatures.
Very cool. Very cool. Is that it, ma'am?
Yes.
Awesome. Thank you. So think thermometer. Thermometer senses temperature. Thermoreceptors sense temperature, hot or cold. And yes, you've got a lot of sensors around your mouth. This is why little kids put stuff in their mouth all the time. There's a lot of sensors here. They're not being weird. This is why we like to kiss. There's a lot of sensors here. Yeah. And it's just fun. Come on. All right. Mr. Ma, you're going to tell us about nociceptors. Sir.
Yes, sir. Nociceptors. So I'm going to make an introduction for nociceptors first. So the nociceptors can be defined as sensory receptors that are activated by noxious stimuli that damage or threaten the body's integrity. Nociceptors belong to the slowly conducting afferent A delta and C fibers. They are classified according to their responses to mechanical, thermal, and chemical stimuli. And so here is the function for the nociceptors. Specialized peripheral sensory neurons known as nociceptors alert us to potentially damaging stimuli at the skin by detecting extremes in temperatures and pressures and injury-related chemicals, and transducing these stimuli into long-range electrical signals that are related to higher brain centers. And so I'm going to give some examples for nociceptors. External nociceptors are found in tissues such as the skin. It's called cutaneous nociceptors.
Cutaneous, yes.
The corneas and the mucosa. Internal nociceptors are found in a variety of organs such as the muscles, the joints, the bladder, the visceral organs, and the digestive tract.
Yeah.
This is all I repaired, sir.
That's perfect. It's perfect. So everybody, nociceptors, nociceptors, they're called pain receptors because they do send a signal to your brain that your brain interprets as pain. You learned that, by the way. They aren't really sensing pain. What they sense is, and people say, oh, they sense extreme heat or chemical, stuff or whatever. That's not even really quite true. What it is that when heat gets hot enough, or when it gets cold enough, or when you get exposed to enough chemicals, or you get stretched too far, actual cells rupture and release stuff. And nociceptors are very good at sensing when cells are being damaged. It doesn't really know why they're being damaged, but so when something gets enough to start damaging cells, cells release chemicals that those nociceptors pick up, and they go dee-dee-dee-dee. The brain's like, that is the signal that we get when tissue is being damaged. And that's why it sends you a pain response, because by telling you you're in pain, it makes you react. It gets your attention. That's what pain does. Pain is your friend. It is meant to get your attention. And so nociceptors are called the pain receptors. There's nothing wrong with calling them that, but they're really damage receptors. That's what they're really doing, is they're picking up when you truly actually start to damage tissue. They're found all over your body, inside and out, because it's important for you to know when your appendix is hurting you. And so that you go to the hospital and somebody knows to take it out. One thing to know about internal pain receptors is quite often the brain is not used to feeling a lot of pain internally. And so sometimes it interprets it as weird stuff. So you're like, something feels weird. I don't quite know what. It's a pain receptor sometimes going off inside you, but your brain's like, I haven't felt pain in my appendix in my whole life. Like, I don't know what that is. And you get some kind of vague sensation down here. And it's because your brain's not used to knowing what that is. Whereas when I touch my finger, I do that so many times, my brain's like, yeah, we know what that is. We're watching ourselves do it. We've done it a lot. We know what that is. Yeah. But anyway, nociceptors, pain receptors. Excellent, Mr. Moth. Thank you, thank you, thank you.
Thanks, sir.
Mr. Lee. Mr. Lee. Mr. Lee, are you there? Last call for Mr. Lee. Okay. Miss Lee.
Hi.
Hi, Miss Lee.
Hi.
Miss Lee, can you tell us, you don't have to tell us a lot, don't feel stressed out, but can you tell us what Alzheimer's disease is?
Okay, I will. Alzheimer's is a progressive disease that destroys memory and another important and mental functions. Brain cell connections and the functions themselves degenerate and die, eventually destroying memory and the important mental function. Alzheimer's is very common that more than 3 million US cases per year. People may experience their cognitive, behavioral, mood, and psychological changes. The first cognitive,
Yeah.
mental decline, difficulty thinking and understanding, confusion in the evening hours, delusion, disorientation, forgetfulness, making things up, mental confusion, difficulty concentrating, inability to create new memories, inability to do simple math, or inability to recognize common things. The second, behavioral, aggression, okay.
That's good.
Agitation, agitation, difficult with self-care, irritability, meaningless, repetition of own words, personality changes, restlessness, lack of restraint, or wandering or getting lost. The third, for mood, anger, apathy, general discontent, loneliness, or mood swings. The fourth, psychological, depression, hallucination, or paranoia, and also inability to combine muscle movement, jumbled speech, or loss of appetite. Alzheimer's disease is complex, and it is therefore unlikely that any one drug or other intervention will never successfully treat it in all people living with the disease. Still, in recent years, scientists have made tremendous progress in better understanding Alzheimer's and in developing and testing new treatment, including several medications that are in late stage clinical trials. Most medications work best for people in the early or middle stage of Alzheimer's. However, it is important to understand that none of the medications available at this time will cure Alzheimer's.
Perfect, Miss Lee. That was perfect. Those are super big words. You do not need to apologize. Many of us here struggle with those words. So anyway, that was really well done. Thank you, thank you, thank you. Everybody,
You're welcome.
for those of you not familiar with this disease, it is the most common form of dementia. There are other forms of dementia. And they believe it is caused by a buildup of protein. It's really like plaque forming around the nerves in your brain. And this plaque causes the nerves to kind of get tangled up and misfire together. And this plaque, you guys have these proteins in your brains too, but for whatever reason you are pulling them out of your brains constantly. And for some reason, when some people, not everybody, get older, they stop removing that plaque, those proteins, and they build up this plaque and they mess up the nerves in their brain. And all those nerve connections are what make you who you are, and it especially messes with people's memory. And the problem is, if you think about it, memory is kind of the basis of everything that you do and know. You know, you get up in the morning and I say, I'm Mr. Tapscott, I'm a school teacher, I teach massage, that's who I am, and therefore I know to put on my scrubs, I know to do the next thing. When I lose some of that, it becomes very confusing. And quite often they're aware something's wrong, but they can't figure out what's wrong, and it's just very difficult. It's also obviously very difficult on the people that love them. Can they get massage? Absolutely. If it is very helpful to have, though, a family member around there, because it is not uncommon for somebody with Alzheimer's to all of a sudden not realize where they are. And when they don't realize where they are, they're going to be upset, angry, all the stuff that we would be. So it does not make people angry, but the problem is not knowing where you are and being scared makes you angry. And so that they can become disoriented. It's very helpful. I've worked on people with Alzheimer's. There's really no consideration except to have a caregiver there in case they don't remember. And by the way, they often don't remember the caregiver when that happens, but at least you have a family member there to deal with that, because you can't deal with it. There's nothing to do. So that's all. That's it. That was excellent, Miss Lee. Big, big, hard words, yes. Mr. Lee, I see you raised your hand, sir.
Yes, sir. Sorry, sir.
Yes. Well, welcome back, sir. Would you like to tell us about chemoreceptors, sir?
Okay, let me try
Oh,
and
sorry.
read this.
Not chemoreceptors, mechanoreceptors.
Okay. Okay, I can't read the big word first.
It is. a big word.
Mechanoreceptor detect stimuli such as touch, pressure, vibration, and sound from the external and internal environment. They contain primary sensory nerves that respond to changes in mechanical displacement, usually in localized region at the tip of the sensory. So dendrite, this what word? Dendrite the word. Mechanoreceptor.
That was good. Mechanoreceptor. That was good.
Often surrounded by complex extracellular I don't know how to pronounce this word, you know? Structures?
Structures?
Structures.
Yeah.
Okay. Couple displacement receptor current, the resulting receptor potential is usually encountered into action potentially by voltage activity. Ion changes may offload micronerves. I cannot pronounce there. Micronerve nerves also receive systemic inputs from the central nervous system data, moderate their sensitivity and possibly the dynamic responses.
I would help you with the last part, but I didn't catch it, sir.
Pardon me?
I would have helped you with the last word, but I didn't catch it. I didn't hear what you were
last
saying.
word.
It's okay. But it's okay.
Dynamic responses.
Oh, maybe mechanic responses, which would make sense. Yes. So, that's good,
Yes.
sir. So,
Thank you. It's okay.
So, mechanoreceptors, guys, are not one type of receptor. It's a whole category of these things that are on the ends of nerves. Mechanoreceptors, though, really help you to know what you're doing mechanically. So we've already kind of talked about some of them. Golgi tendon complex, organs, and muscle spindles. But you also have mechanoreceptors in your joints that tell you how far your joints are going, how much they're stretching, how much pressure's on them. They also sense pressure too, so like I can feel my mechanoreceptors on my feet telling me how I'm standing. They truly, by the way, give you a sense that you are here in the world and that you're not dreaming. They give you a sense of where you are in three-dimensional reality with your eyes shut. Mechanoreceptors really let me know what I'm doing right now and how silly it looks with my eyes shut. Yeah. Awesome. Thank you very much, sir.
Thank you, sir.
Okay. Mr. Jones. I hope.
Hello.
Yes, you're paying attention because you're supposed to tell us about attention deficit, or
I
hyperactivity
know.
disorder. Yes.
I happen to have it, so I understand, man.
Well, I'm sorry I made a joke then too. I was just trying to be cute.
Oh no, it's it's a real joke. That's not even a joke. That's
No.
a fact.
Yeah. So tell us about it.
All right. So, ADHD is a neurologic disorder in which the affected person displays behaviors associated with attentiveness, hyperactivity, and impulsivity, or a combination of the three. It can be many different variants of those three. And it's divided into three subtypes. Each one is different. The subtypes are predominantly inattentiveness, with majority of symptoms falling under inattention, predominantly hyperactive impulse, with majority of symptoms falling under hyperactivity and impulsivity, and a combination of those two.
Very cool.
So ADHD can be observed at any age, and it can be diagnosed at any age, but typically it starts as a child, and it can go into adulthood, and sometimes it gets worse, sometimes it might lessen. It's kind of different depending on the person. All right, and then so I also looked up something online because I was curious.
Okay.
So, like as a child, traumatic stress, it doesn't cause ADHD, but it can lead to it. I'm not really sure why that happens.
They think because you disassociate. Yeah. They think because you disassociate, sir. So traumatic stress makes you kind of separate yourself from things, and that gives you that can give you symptoms of attention deficit disorder. Yeah.
Exactly.
And that makes sense.
For massage, I'm going to just read this from the book. But it says, so adapt the length of the session to the client. The therapist may find shorter than normal sessions more appropriate for some clients. Therapists will likely face challenging situations when working with adult clients who have ADHD. These situations range from excessive fidgeting and talking during the massage to missed appointments and forgotten wallets. Being tolerant is advisable, but too much tolerance may lead to unforced office policies. When working with children with ADHD, teaching parents or caregivers how to give a relaxing massage to the affected child is beneficial. Making massage more accessible and giving caregivers another tool to take care for and nurture their loved one. Each technique is taught to light effleurage or similar techniques to convey the same precautions licensed therapists follow, such as avoiding skin lesions. Some children and adolescents with ADHD are hypersensitive to some forms of stimulation and may not like to be touched, so be patient and accepting. And I feel like that goes in line with the trauma thing. They might not have just been born with this, and it could be caused from extreme stress or things like that. So they might just need love, essentially.
Don't we all?
Yep.
Yeah, I love it.
And then massage can also help the children focus better in the classroom, better anger control, improve social function, and more restful sleep.
Yeah.
So it will definitely benefit them.
Yes. It's completely, there's really no considerations in a way from a massage therapist's point of view, right? They're just individual
Yeah,
stuff.
exactly.
Yeah.
Always massage them, just be understanding, essentially.
Yeah. And by the way, my students, fellow future massage therapists, I don't know why. Anyway, this is one of those things that's on a spectrum, right? We all have symptoms at times of ADHD. Some people have it much, much more severe than others. Also, this is something that a while ago, they used to sit a kid down to see if they had ADHD and ask them to read like a page from a book. And if they seemed to get distracted, they'd be like, oh, well, you have attention deficit disorder. Well, asking kids to read a boring page from a boring book is not a really good test. They have since changed this test quite a bit. And they really look for, do you get distracted when you're doing things you are interested in? Because you should get distracted when you're doing things you're not interested in. If I'm like, let's study paint drying tonight, I would hope you guys would have a hard time focusing on that. So, anyway, it's all over the place. But yeah, no consideration for massage. Thank you very much. That was perfect, sir. Thank you.
Of course.
Miss Hendrickson, autism. Speaking of spectrums,
Okay, yes. I was like trying to open it, but I have to unmute myself first. Well, autism has a lot of similarities to ADHD in that it's on a spectrum and it can have similar ways you would treat it in massage and how you need to just be tolerant. But let me start at the beginning here. Autism spectrum disorder, as defined by the Diagnostic and Statistical Manual of Mental Disorders, is a condition present in early childhood characterized by difficulty communicating and forming relationships. Embedded within the diagnosis or umbrella of autism spectrum disorder are Asperger's syndrome, pervasive developmental disorder, it's not otherwise specified, childhood disintegrative disorder, Rett syndrome, and all previous subtypes of ASD. So it used to be like number system, but they changed it. The behaviors associated with ASD usually become apparent in the second or third year of life, but may not be recognized until later, especially if the case is mild. It can be diagnosed as early as 18 months, though. Levels of functioning are categorized as mild, moderate, or severe based on accompanying symptoms. Several factors may influence the development of autism, and it is accompanied by sensory sensitivities and medical issues such as gastrointestinal disorders, seizures, or sleep disorders, as well as mental health challenges such as anxiety, depression, and attention issues. I found this very interesting. There's a lot of conditions that are pretty low percentage of the general population, but people with autism have a much higher rate of having these issues. So gastrointestinal problems, feeding issues, disrupted sleep, ADHD, anxiety, depression, obsessive compulsive disorder, schizophrenia, and bipolar disorder. GI disorders are nearly 8 times more common among children with autism than other children. They can include chronic constipation, abdominal pain, gastroesophageal reflux, bowel inflammation, and epilepsy affects up to 1/3 of people with autism, but by contrast, it affects only 1 to 2% of the general population. In 2020, the CDC reported that approximately 1 in 54 children in the U.S. is diagnosed with an autism spectrum disorder, according to 2016 data. So it's very common. 1 in 34 boys identified with autism and 1 in 144 girls. So it's much more common in boys, about 4 to 1. Most children are still being diagnosed after age 4, though it can be reliably diagnosed as early as age 2. So 31% of children with an autism spectrum disorder have an intellectual disability with an intelligence quotient of under 70 IQ points. 25% are in the borderline range with 71 to 85. And 44% have IQ scores in the average to above average range, which is over 85. Autism affects all ethnic and socioeconomic groups, but minority groups tend to be diagnosed later and less often. Early intervention affords the best opportunity to support healthy development and deliver benefits across the lifespan. There's no medical detection for autism, and I'm just going to throw this out there because I found it on the website. I hope nobody believes this anyway, but vaccines do not cause it. There's been a lot of research and there's no link between them. Research indicates that genetics are involved in the vast majority of cases, and children born to older parents are at a higher risk for having autism. Massage can be helpful for clients with autism spectrum disorders. It can decrease touch aversion and orientation to extraneous environmental sounds. It's been shown to increase on-task behaviors, reduce tactile impairment, and promoted social relatedness, and better sleep. Teaching parents to give massage to their children with autism can be very helpful because it helps parents experience less stress and build a stronger physical and emotional bond with their children. And these feelings persisted with continued massage. In the clinical setting, there are some important questions to ask clients with ASD. In their first massage, be sure to ask about intolerances to touch, as well as other hypersensitivities such as sounds, smells, and textures, and make modifications to treatment with needed. They have a preference, strong preference for sameness and routine, so it's recommended to establish a routine in your massage and repeat that same routine with subsequent sessions. And this preference also extends to placement of furniture and fixtures in a massage office, so they can be really distressed by changes, like even if, say the furniture was arranged differently or a picture was moved or something like that. A sideline position may be more comfortable for them, especially if this is how they tend to fall asleep. Weighted blankets may be helpful and comforting, and shorter sessions may be more appropriate, at least during the first few sessions, to learn how the client handles the massage. And if they show any signs of distress, it's advised to discontinue and reschedule for another day.
Yeah.
And
Good.
that is all I have there.
Thank you. Hey, and by the way, I'm not saying you should think about it this way, but there is a big push coming from autistic individuals to say, don't necessarily look at this as a disorder. This is a different way of ordering the world, right? The reason, and I really like that out view, I really do. We have a very difficult society to fit into. And if you fit into it well, let's suppose you're able-bodied, because heaven forbid you're handicapped, physically speaking. We don't have a world built very well for those individuals either. And if you look at the world the way I do, right, the way most of us do, then it's okay. But if you're slightly different, then all of a sudden it's a very frightening world and society, and it's very hard navigating it. And so there are lots of autistic individuals who do incredible contributions to society. Look up Temple Grand. She's amazing. Does all this work with animals in the animal industry and stuff like that. She's brilliant, and she's different. And she's one of the people pushing for this is, hey, this is a different way of thinking. This is not a better or worse way. It's just not a way you're used to. And so society is not built to make it hospitable for autistic individuals. Yes, Miss Eversole.
I was just gonna say too, I was gonna agree with you because two of my brothers are on the spectrum as well.
Yeah.
And both of them are like, no, like I'm capable of doing everything, including working and buying my own house and having a family. It's just the fact of I might be socially different or it might be harder to understand. But other than that, they're the same as anyone else.
Yeah, yeah. We're all quirky. Everybody's quirky.
Yeah.
I don't know if you guys know the comedian Amy Schumer. Her husband is autistic, and she loves it. She says she has trust issues in relationship, and most autistic people don't lie. It doesn't make sense to them because they don't read social cues, so they don't think to socially lie. So she's like, he tells her exactly the truth about everything. And she's like, it's the greatest thing ever. She goes, he's blunt. He'll be like, yeah, those jeans make you look fat. Like, whatever she asks him. But she's like, I love it because I'm in a relationship with somebody that I completely trust. He loves me, and he's completely honest, and there is no coloring it rosy for me. It's just the truth all the time. So there's all these wonderful things about autistic individuals too that we don't possess. By the way, most non-autistic people, everybody here, most of us lie all the time. Now, I don't mean you lie about important stuff. We lie about social stuff all the time. Oh yeah, no, that's not so bad when it is, all that kind of, we do that all the time. That's actually part of fitting into society. Miss Hendrickson.
Yeah, I found it really an interesting topic, and I found a lot more information, but I didn't want it to go on too long. But I had a boyfriend in high school who had Asperger's syndrome, which is under the umbrella of autism, and I definitely recognize the symptoms like light sensitivity and not really understanding social cues very well, and not having like a good understanding of like his own voice and tone and volume and things like that. So I was like, wow, that's really interesting. But and also how it really affects families so much because they have, they spend so much money on all these services and time and everything, and it's really common. I didn't realize it was like that many, like that high of a rate of kids. So it's a real challenge for people that have, especially the kids that have like the really low IQs or really hypersensitive.
That is much more challenging.
Yeah.
Very cool. Thank you. Mr. Manzanares, I am so sorry I skipped over you. I think it's because, I don't know. Actually, I know why it is. It's because I connected one thing with another. But can you quickly just tell us what an osmoreceptor is?
Yeah.
Thank you. Thank you. I can hear you, and I'm sorry, and thank you. Yes, please tell me.
Just fine. I was just scared. Okay, so osmoreceptors are they're located in the hypothalamus, in the vascular of the lamina terminalis, and osmoreceptors are neurons that are endowed with okay, I don't understand my handwriting, but ability to detect changes in ECF are capable of sensing the concentration of solute, particularly sodium ion, and at the same time the thirst center in the hypothalamus is stimulated and is using water consumption. And that's all I wrote down.
Okay. So, thank you, sir. Osmoreceptors sense osmotic pressure. We won't have to deal with this in massage. In a way, they're kind of like salt receptors. You have them in your brain and your kidney, and your salt balances are extremely important in your body. So they sense osmotic pressure, which is really the pressure between membranes, but a lot of that has to do with your salt content. And they are monitoring the internal chemistry of your body. That's what's significant about them. All right, moving. Right, and sorry, sir, that we did that out of order and all that kind of stuff. Moving right along. Miss Green.
Hi.
Hi, can you tell us about Bell palsy?
Okay, so Bell palsy is a neurological condition of the facial nerve, causing weakness or paralysis of muscles on one side of the face. It can last a few months, or it can be permanent. It is often first noticed in the morning after having developed overnight, basically. It says that it equally affects men and women, and usually it's around the ages of 20 and 60. It affects approximately 2 in 10,000 people in the United States. What causes damage to the facial nerve is often unknown, but viral infections are often implicated, usually herpes simplex. And then benefits for massage therapy. So techniques like light pressure, effleurage, and petrissage on the face in upward motion are things that are supposed to be helpful to manage symptoms and promote relaxation in the face. Stress and anxiety definitely make it worse. You may, as a massage therapist, if you encounter a person that has Bell palsy, you may want to instruct them when they go home to massage their own face 2 to 3 times a day and show them different, I guess ways to kind of go about massaging their own face, basically, directions to kind of go and, pressure to kind of apply and kind of, because, when someone's showing you how it feels, you can you know, you feel how it feels, so you know how to apply it. Basically.
Yes.
Facial massage is recommended frequently to help speed the recovery process of Bell palsy as well, if it is not going to put you in a paralyzed state, basically. And that's it.
Cool. Yeah, it comes and goes for a lot of people. It is often a viral infection. Herpes stores itself in your nerves. The virus stores itself in your nerves, and it's kind of like, like chickenpox, by the way. Chickenpox stores itself in your nerves, and that's how you can get shingles later. And that's why this can often be, by the way, it's not the only cause, but that's why it is a viral infection that quite often stores itself in your nerves. And stress means your immune system doesn't keep it at check, and it comes out. And when it comes out, it can attack nerves. And if it attacks your seventh nerve for your face, it'll cause this droopiness. And because it's a virus, it can go away.
And also it affects your speech too. Like,
sure.
You have like a speech impediment.
Yeah. And by the way, if it's really bad, it doesn't go away. And you guys have probably seen somebody of this before, because part of their face is drooping, and you're like, oh, and it takes a second, but it kind of hits you. There is no contraindication for massage. You can massage away. It's all good. It's
interesting because I know like strokes make your do weird thing for your face.
Sure.
And usually it's like one side of your face as well.
Yeah.
And so I was thinking like, oh, they're kind of similar, and it's like interesting. They're kind of similar but different.
Well, and a stroke is usually much more severe, because a stroke is usually an actual problem in the brain, where brain damage has been done. This is just kind of like a nerve being disrupted. Yeah.
Right.
But you're right, they show themselves similarly. You're right, Miss Green. Miss Pugh, you raised your hand, madam. Thank you.
Yeah, my mom had Bell's palsy when I was a teenager.
Yeah.
And I think she was just really super stressed out when she got it. And like half of her face did shut down and her speech was slurred. And she was really cranky at that time.
Yeah.
And she couldn't work. I had to go get her medications and stuff for her because she just stayed home and recovered.
Oh, wow. But it went away.
It's crazy.
And it went away eventually.
Yeah, but I think a week or two it went away.
Wow.
Maybe a month max.
Yeah, very cool. Interesting. Miss Hendrickson.
Yeah, this kind of came to mind one time when I was working as a server. I had a customer who was had a really hard time like eating, was making a lot of mess, and his speech was slurred, and I thought he was drunk, and then and I was like, do I need to cut this guy off? It seems like he's slurring his speech a lot. And then his wife that was with him was like, yeah, he really has a hard time because he had the stroke, and I was like, oh my god, I feel so bad that I didn't realize this, and I didn't say anything, but I was like standing around, like I was standing like a ways away, kind of like observing him, like, do I need to cut him off? And I was like, oh man, I was so embarrassed that I just like assumed he was drunk, and I was like, oh my god. But yeah, just be really careful and don't assume things. It's kind of like hard when it's your job to like make sure people aren't drunk, but.
Well, that's the problem, right? I'm glad you brought this up, because strokes and like diabetics when they get low blood sugar, a lot of these things present themselves very similar to how somebody is when they've been drinking. And so it's just good for us to keep in the back of our mind. Your client really might have been drinking, by the way, okay? Especially if they show up. But if you see somebody have these changes in front of you, it's really a sign there's something wrong, right? And so it's just a really good thing to look. And that's the first thing that comes to mind. You're like, is this person drunk? But then flip through these other things. This could be other stuff I'm seeing. So it's very helpful. I'm glad you said that. That happens to everybody. That mistake. It's very hard to tell. But it's a good warning sign. If you're living with somebody and you're like, are they drunk at 8 a.m.? They're probably not drunk at 8 a.m. unless they're always drunk at 8 a.m. It's probably a very severe thing and you rush them to the hospital. Yeah. Okay. Fantastic, Miss Green. Mr. Godot. Carpal tunnel syndrome, by the way. We all have a carpal tunnel.
Hello.
Hello, sir.
All right. Let me get my stuff ready. Alright, so I have carpal tunnel syndrome, and basically it's a numbness and tingling in the hand and in the arm caused by a pinched nerve in the wrist. Basically, it'd be underlying health conditions and patterns of hand use that can contribute to carpal tunnel syndrome. So basically, it requires a medical diagnosis, but the symptoms are pain in the hand and arm, also numbness or tingling. So, I mean, you can't tell what it is. Like, it'd be better to get a diagnosis, but you can also see the symptoms. So, also with that, you may also experience hand numbness, sensation of pins and needles, hand clumsiness, so you might drop things a lot, hand pain at night, hand weakness or wrist weakness. So it's just constant pain. It sounds like basically like chronic pain in your hands. Basically, for treatment, you could try splint. There's not really medications other than steroids and like anti-inflammatory drugs. And then you can also try surgery, which is like the biggest step. But there's also ice packs, rest and therapy and stretching. But it's really kind of, to me, it sounds like there's not an actual certified like treatment as far as like when you break something or anything. It's just kind of based on your body, and you have to keep trying to treat it through rest and recovery type of thing.
I love what he said there. There really is, there are some treatments for carpal tunnel, but there's not really one agreed upon really good treatment for it. Did you have anything else, sir? By the way, I didn't mean to cut you off.
No, that's all I had.
So everybody, carpal tunnel it's a big one. You will have clients come to you. Usually people talk about weakness in the hand. We don't diagnose. We don't know if they've got carpal tunnel when they come to us, but that implies a nerve problem. You can see the slide up here right now. This is really important to massage therapists. This is your flexor retinaculum here, and it attaches to the muscles over here on your hypothenar eminence, your pinky pad, and your thenar eminence, your thumb pad, which means this can be stretched out. Massage therapists can stretch this out. Miss Rader, Miss Carrillo, and Mr. Ma, we talked about this, right? This can be stretched out right here to make more room underneath the carpal tunnel. And that's a really good thing to try first. The reason some surgeries will actually cut this or clean out under the tunnel, and the problem with that is you usually get scar tissue and it comes back again. Also, this nerve right here, this median nerve and this ulnar nerve could be pinched further up the arm. And I really hope they eliminate that possibility before they cut into somebody. I think I've got an actual hand here, so those of you that thought it was cool, the leg, but also felt like throwing up. By the way, this is a symptom of it too. If they've had it for a long time, there's no nerve impulse going to the thumbs, and the thumb pads start to degenerate, right? The muscles get small, they're atrophying. This is a very severe case, actually. And this is when they will actually go in and cut the carpal tunnel to try to make more room for it underneath there. I do not like this approach, as you can tell. I think it's a very severe route to go, but it can be done. Some people have the surgery more than once because it only works for a while the first time, which also worries me. You can grab on to the pinky pad and the thumb pad, the thenar eminence and the hypothenar eminence, and spread open the hand. You don't rub right in here, but you pull this side out and you pull this side out to open up the carpal tunnel. You don't need to make much difference in there. Over time, that can make enough difference. But Mr. Godot is right. They also need to do some lifestyle changes. They need to get up from their computer more often, all that kind of stuff. Because if they don't make lifestyle changes, it doesn't really matter what a surgeon does or you do. I thought I had a picture of, sorry. But one of the things I do is I massage the flexors and extensors of the forearm because they add to that kind of pressure. I massage the whole upper arm, the brachial region. I hit the pectoralis minor and the scalenes in the neck because that's where the brachial plexus comes out, and I widen the hand. So I hit this whole nerve kind of complex there. I just wanted to show you all that. Good job. Awesome. Thank you, Mr. Godot. And next up, we have... Oh, Miss Clayton, please, talk to me.
That just made me think of something. So when you talked about how you do it, you work the scalings and widen the hand and all that, is there any kind of, and I'm sure you're going to say, well, we just know this by learning the muscles, but is there any kind of like reference material that says, if client comes in with this, here's the 5 things we recommend doing?
Yeah, you've kind of mentioned this before. Have you ever searched, I know this is brushing you off, and I don't mean it that way, but have you searched on the internet? I have never looked for something like that, but I would suspect some therapist out there has put out a, when I come across this problem, we do X, Y, Z. Now, I mean, that's what we're doing in this class now. I'm saying when you come across carpal tunnel, everybody, you loosen up scalenes, you loosen up the subclavius, the pec minor, you hit the whole brachial fascia here, just rubbing that out. You loosen up around the elbow, you hit all the forearm flexors and extensors, and then you try to widen the carpal tunnel. That is my protocol for working on carpal tunnel. Because, by the way, carpal tunnel could be thoracic outlet syndrome, and it could be cubital tunnel, which means the nerve could be pinched in these 3 areas. It might be all 3. A minor pinching here, here, and here shows up as major hand weakness. So I always get very worried when anybody, surgeons, massage therapists go, oh, it's that one thing. I don't know about you guys, but there is not one thing in my life that, I gotta.
Yeah.
There's not one thing in my life that causes every problem, right? It's usually multiple things that I have to change. So, but there's no harm done. I hit all 3 of those. So anyway, Ms. Clayton, in this case, that is my protocol right there. If you want muscles, it's scalenes, subclavius, pec minor, flexors, extensors, and then there's fascial work too that needs to be done. Opening the flexor retinaculum and just massaging the fascia of the brachial region, which would be bis, tris, brachialis. And that's just to keep all the nerves there, like, unimpinged. Yeah. But for, like, every condition out there, I don't know. Search on the internet and see if there's a document. I've never seen anything like that, but I would think somebody would have put something together like that. I hope that helps. Miss Eversole, double crush syndrome, which I just kind of alluded to, actually.
Yes, hello.
Hello.
I'll get to my notes. So, double crush syndrome. There wasn't too much in the
There's
book
not a lot
about
to
this.
say about it. That's what I was about to say. It's just tell us what it is.
Yeah, so it's a compression at 1 or 2 locations along the peripheral nerve. Is that how you say it? So in the book there was an example. It said the coexistence of the brachial plexus compression at the shoulder, the thoracic outlet syndrome, and the median nerve compression at the wrist, or carpal tunnel syndrome. And then it was talking about massage therapy. It told me to go to the thoracic outlet syndrome and the carpal tunnel syndrome. So for massaging those, for the wrist, you can massage the muscles in the forearm and the palm of your hand. You can also stretch it. That massage can improve the grip strength, and combined with the trigger point massage, it can decrease symptoms of carpal tunnel syndrome. And then for the shoulder, you can use trigger points, cross fiber friction, muscle stripping, and gentle passive stretching of the shoulder.
Yeah. By the way,
other than that, I tried to look up some more online, but there really wasn't anything.
Miss Eversole, that's all I would say about it. So, but by the way, I'm glad she threw in stretching. I should have thrown in stretching. Stretch, 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 stretch. Rub and stretch.
Yes.
But double crush syndrome just means a nerve that's pinched in 2 areas. I think usually when you're having a pinched nerve, it probably is double crush syndrome, or triple crush syndrome, or quadruple crush syndrome. We don't know where the nerve is pinched. So with the brachial plexus, it's very common that it's pinched up here in the chest. That's thoracic outlet syndrome. And down here in the wrist, that's carpal tunnel. But quite often you have both conditions together and they just show up as carpal tunnel. People go, oh, your hand's weak, you've got carpal tunnel. Well, I might have thoracic outlet syndrome too. It's the same nerve. So the only thing important to remember about double crush syndrome is don't look in one place. work the whole nerve plexus, whatever it is. Work the whole leg, the whole arm when you think there's a problem down that goes work from the spine to the problem. Unless you're 100% sure that, oh, the problem is just right here or just right here. Fine then. But usually I work the whole line of the nerve, just in case. Cool, perfect, thank you. Miss Everson, can you tell us about herniated and bulging discs?
Sure, can here.
Getting there, I can hear you, yep.
Am I still on the bunch of the phone?
Oh, wait 1 second, Miss Everson. I just realized there's hands up, and I did not answer these questions. Hold on, I'm so sorry. Miss Rader, did you have a question about double crush? Or comment?
No, not specifically about that. Just going back to what Miss Clayton's question was.
Sure.
In this chapter, there was a recommendation for a book called Mosby's Pathology for massage therapists. And it also, when I looked it up on Amazon, it said that it also offers specific therapeutic exercises and stuff like that.
Cool.
So,
Awesome.
yeah.
Thank you so much.
You're welcome.
You're very smart. Thank you.
We might, after I just told you I didn't know if there was a book like that, Miss Clayton, we might, no. I was thinking we might even have that book here, but I think it's underneath the ceiling at Deer Valley. But yeah, Mosby's Book of Pathologies. I forgot all about that book. Thank you. Thank you. Miss Clayton, did you have more? Your hand's still up. I just want to make sure you're cool.
No, thank you.
Cool. Miss Everson, thank you for your patience. Take it away.
Okay, let me get back to the notes. Alright, herniated discs and bulging discs. Discs are, say that 5 times fast. Discs are cushions between the vertebrae and your spine that acts as a shock absorber. They consist of 2 different cartilages, the nucleus pulpits, which is the center, made of roughly 80% water as well as collagen fibers, and surrounded by a tough elastic-like band called annulus fibrosus, consisting of 7 to 15 fibers that surround and protect the nucleus itself. So bulging discs. Bulging discs are more common than herniated discs and usually happen with age as it slowly degenerates. Only the outer layer of the cartilage is involved in bulging discs. This can cause pain in the buttocks, legs, or back and may affect the ability to walk. Fortunately, anti-inflammatories, steroid injections, and exercise routines can be done to alleviate pain before surgery is considered. Meanwhile, herniated discs are considered more severe and occur when there is a crack in the tough outer layer of the cartilage that allows the inner layer, which is the nucleus, to protrude out of this disc. This makes it more likely to have pain due to the bulge putting pressure on potentially nerve roots or the spinal cord. This may cause irritation and inflammation in both of these locations. Herniated discs are usually caused by an acute injury, such as lifting with your back rather than your legs, consistently twisting, or bad posture. So take care of yourself, guys, and work on your body mechanics. Pain can also be felt throughout the arm and leg, causing burning or tingling sensations in the affected areas, muscle weakness, as well as pain that worsens after prolonged sitting or standing. Pain and numbness that radiates down one side of the body and can become more severe during the night. So unfortunately, smoking tobacco,
And Tabasco. Both.
Tabasco. Please smoke Tabasco. Unfortunately, smoking tobacco increases the risk of herniated discs because the nicotine actually reduces the flow of blood to the vertebral discs. Not only does this increase disc degeneration, but it also slows down the healing process. As well as you have a risk of herniating a disc is increased if it is hereditary in both or one side of your family tree. such as your parents, as well as obesity, because it causes more strain on the spine. So, those are the three main things to stay away from if you can control it. And a common misconception is that massage should be avoided in these areas for fear of pushing on these discs. And this is very false. The discs are actually usually slipped in the other direction, and so pushing on the spine and getting into those faucets aren't going to damage it. If anything, it may irritate the nerve if it is already being pushed, but very slow pushes and communicating with your client can prevent this.
I love it. I love it. Thank you for the last part. Yes, this is what I would say. By the way, herniated discs, bulging discs, slipped discs are essentially all the same thing. Sometimes somebody will argue with you, well, but they mean a disc coming out from where it's supposed to. Essentially, you guys have really tough, really awesome jelly donuts between all of your vertebrae. And the outside is really hard, the inside is kind of smushy to be shock absorber, and if the outside ruptures, the jelly on the inside comes out. And you have all these nerve plexes, these branches that come off your spine between the vertebrae, and that jelly pushes all of those nerve plexes, which is a whole bunch of nerves coming out to like feed an area, right? Millions of nerves coming out that area. So it's not pressing on your spine, but it's pressing on nerve plexus, and that's a lot of nerves being pressed at once. That's very painful. That causes problems. Massage is rarely, nothing you need to avoid. It's something you probably should do. Sometimes the client's afraid of you doing it, so don't if they don't want you to. But if they get referred pain, which means if when you push on them, that then it's shooting down to another area of their body, stop doing that. That means you are pressing on the nerve. You're not going to kill them. You're just that stuff. But if it hurts in that area and they're okay with it, you're golden. The last thing I want to say, too, is because of where the disc is bulging, believe it or not, even though we bend over and flex, because everybody's like, oh, I'm tight back there, that's fine, but that actually tends to make the bulging worse. Extensions tend to push the bulge back in a little bit. And so doing like a cobra stretch, doing extensions actually tend to help the client over time. They didn't know this a little while ago. And they're very effective. So having the client do these kind of cobra stretches where they push themselves up on the ground, things like that, can be very effective. So it's kind of counterintuitive, but just something to know. Miss Everson, I'm sorry, you had your hand raised?
So from my reading, it said that bulging discs and herniated discs were not the same thing. Those two are different, but herniated discs can be called slipped discs, the other thing you mentioned.
Yeah, by the way, I stand corrected, but what I mean is they're going to make the distinction that one's more severe than the other. They're all discs that are pushing out. Yeah. Cool. Thank you. I hate to start another presentation because I'm worried we won't have time for it. So we still have 7 amazing presenters to hear from, and we will do that on Monday. So on Monday we'll hear about migraine headaches and multiple sclerosis and Parkinson's disease and sciatica and seizure disorder and thoracic outlet syndrome and trigeminal neuralgia. And I'm sorry we didn't hear from those 7 people today. I apologize, but I've made